Hello everyone. In today's session, let us look into the management of double outlet right ventricle. So I am going to give an overview of surgical management of double outlet right ventricle. There are no physical findings or ECG criteria that can distinguish DORV from the other congenital heart diseases with similar clinical features. Usually ECG shows right axis deviation and right ventricular or biventricular hypertrophy. Chest X-ray findings are varied and non-specific, which in turn depends on the amount of pulmonary blood flow and the presence of associated major cardiac anomalies. In patients with unrestricted pulmonary blood flow without pulmonary stenosis, the features resemble those of pulmonary overcirculation. Those with pulmonary stenosis, the X-ray features are more of pulmonary oligemia. In patients with L post aorta, a vertical left upper mediastinal aortic shadow is seen in posterior lateral X-ray, which is non-specific. Echocardiography is the cornerstone for the diagnosis of double outlet right ventricle. It can give us the information on diameter, location, number and commitment of the VSDs, the origin of both great arteries and their relationship to each other, semilunar atrioventricular wall continuity or discontinuity, and the status of the left ventricular outflow tract. It can also give us the information on right and left ventricular volumes, pulmonary stenosis, atrioventricular wall abnormalities such as straddling or overriding, abnormal insertion of the tensor apparatus, the distance between the tricuspid and the pulmonary annuli, which is very important while planning intraventricular tunneling, abnormalities of systemic and pulmonary venous return, coronary artery anomalies, the presence of complete atrioventricular canal defects. Cardiac catheterization is not performed routinely nowadays unless there are anatomical features that are not adequately elucidated by the echocardiography. If performed, we should look into the following features in a case of DORV, that is the size and relationship of the VSD to the great arteries, the presence or absence of multiple VSDs, the relationship of the great arteries to each other, the presence or absence of the pulmonary stenosis and the level at which it occurs, coronary artery anatomy, the presence and level of left ventricular outflow tract obstruction, the relationship of the atria to the ventricle, whether they are concordant or discordant, and other associated cardiac anomalies. It is mainly reserved to define associated cardiac anomalies that are not clearly identified by the echocardiography, such as coronary artery anomalies, peripheral pulmonary artery stenosis, etc., to provide an integrated image of the pulmonary arteriality and to define irreversible pulmonary vascular diseases. As you can see in the diagram, it is a cardiac catheterization of a patient with DORV, where you can see bilateral coni and the VSD is next to the pulmonary artery, which is classically seen in patients with thoracic being variant. Magnetic resonance imaging is done to document the adequacy of the ventricular volumes for biventricular repair. In elucidating coexisting cardiac anatomy such as abnormalities of systemic or pulmonary venous connections and other abnormalities in some complex cases. The goal of the treatment in a case of DORV is a complete anatomical repair, wherein left ventricle is tunneled to the aorta through the VSD and the right ventricle to pulmonary artery communication is established. Timing of the surgery depends on the symptomatic state of the patient and anatomy of the DORV and the major anomalies associated with it. The anatomy determines the ultimate corrective surgical approach, which in turn influences the optimal age for definitive repair. In general, a complete repair is undertaken as early as possible. There are certain impediments to the complete anatomical repair, which include presence of ventricular hyperplasia, serious abnormalities of the either atrioventricular wall, the presence of very remote or multiple VSDs, the presence of irreversible pulmonary vascular disease. In general, the anatomy is assessed through the tricuspid wall and a repair is planned in a case of DORV. The repair is performed through the tricuspid wall and or vertical right ventriculotomy incision. Sometimes, when the repair is carried out entirely through the tricuspid wall, exposure of the most superior portion of the VST is enhanced by performing a radial incision along the base of the septal and anterior leaflets of the tricuspid wall and or by exerting a gentle external pressure at the aortoventricular junction. Let us look into individual VSTs. DORV with subaortic or doubly committed VST without pulmonary stenosis, which approximately account for 20% of all DORVs, and in 20% of these cases the VST can be restrictive. Complete repair is attempted in early infancy because of the early onset of pulmonary vascular disease. It has also been shown that younger age per se is not a risk factor for hospital death. Intraventricular tunnel repair is done in these patients wherein left ventricle is connected to the aorta. Rarely in patients with refractory congestive heart failure who are thought not to be immediate candidates for complete repair, pulmonary artery banding is done. If the VSD appears to be restrictive, that is defined as the diameter less than that of the aortic wall, it is enlarged by making an incision anterosuperiorly or by resecting a wedge of the interventricular septum in this area. As shown in this figure, the VST is restrictive, hence it has been enlarged anterosuperiorly and a part of the interventricular septum being excised. The left ventricle is tunneled to the aorta through the VST. You can clearly see the distance between the tricuspid wall and the pulmonary wall is more than the diameter of the aortic annulus, hence facilitating a smooth intraventricular tunneling. In cases of intraventricular tunneling, care has to be taken not to injure the mitral wall or its tensor apparatus and to avoid the injury to the anterior ventricular wall with its left anterior descending coronary artery and the septal perforator. Obstructive right ventricular muscle bundle should be resected. It is usually possible to reconstruct a tunnel from the left ventricle to the aorta without obstructing the pulmonary outflow tract if the minimal distance between the tricuspid wall annulus and the pulmonary wall annulus is equal to or greater than that of the diameter of the annulus. As you can see in diagram A, the distance between the tricuspid wall and the pulmonary wall is more than the diameter of the aortic annulus, hence a smooth interventricular tunneling can be performed. In cases where the distance is lesser, either it can impede the pathway of interventricular tunneling or it can preclude the interventricular tunneling operation, subjecting patients to the other modalities of surgical treatment. An appropriately trimmed flat Gore-Tex patch or a tailored Dacron or the Gore-Tex tube graft can be used for interventricular tunneling with either interrupted or running sutures depending upon the surgeon's preference. In patients with fallow type, pulmonary stenosis can range from a relatively mild valvar, subvalvar or supravalvular stenosis to frank pulmonary atresia. Repair is generally advised by 6 months of age if the coronary artery anatomy is normal and if it is felt with certainty that an intraventricular repair can be performed. In patients with poor general condition, major cardiac anomalies, hypoplastic branch pulmonary arteries and need for the conduit, a systemic to pulmonary artery shunt can be performed before a definitive surgery. The surgical principles remain the same. It is tunneling the left ventricle to the aorta through the VST and relieving right ventricular outflow tract obstructions. The RVOT procedure depends on the degree and the type of the right ventricular outflow tract obstruction. In patients with adequate pulmonary annulus and valvar stenosis, we can do a pulmonary valvotomy. Patients who have inadequate pulmonary annulus, we can do a transalveolar patch with or without monocusp valve. Patients with pulmonary atresia or major coronaries crossing the right ventricular outflow tract, we can use RV2PA conduit. Those with subpulmonic VST are frequently associated with aortic arch abnormalities subaortic obstruction, side-by-side positioning of the great arteries, significant diameter mismatch of the great vessels, the aortic wall diameter being significantly smaller than that of the pulmonary wall. These are the different surgical strategies which have evolved over the years for a DORV with subpulmonary VSD, or otherwise called as Taussig-Bing variant. Let us look into the most common surgical procedure performed in a cases of Taussig-Bing malformation. Interventricular tunneling. This type of repair has been accomplished by using a number of techniques. The posterior tubular conduit repair of Abb and colleagues, the anterior tubular conduit method of Doty, the anterior spiral tunnel repair of Patrick and McGoon, and the posterior straight tunnel technique of Kamashima, which is most commonly performed. As shown in the figure, in a Kawashima operation, the conal septum requires resection to construct an interventricular tunnel, and a generous resection of the infundibulal septum is performed in order to create an unobstructed path between the subpulmonary VSD and the aorta. Figure C shows the completed intraventricular tunnel repair, and you can also notice the distance between the tricuspid wall and the pulmonary wall is greater than the diameter of the aortic annulus. So sometimes it is necessary to augment the right ventricular outflow tract in order to relieve the subpulmonary stenosis created by the tunnel, or to relieve the various pre-existing pulmonary stenosis. Arterial switch operation with the VSD closure is the most commonly performed operation for Taussig-Bing variant. The advantages of this technique compared to the Kawashima operation include its flexibility, that it can be used successfully for the repair of Taussig-Bing hearts with any and all arrangements of the great arteries. The arterial switch operation is optimally performed in the first week of the life before the patency of the ductus arteriosus is maintained by prostaglandin infusion. A pre-operative balloon atrial septostomy procedure is usually not required because of adequate mixing at the level of the PDA, the ASD, and the large subpulmonary VSD. So, in the absence of subaortic stenosis, in a case of Taussig-Bing anomaly, aortic arch repair and a pulmonary artery binding through a left thoracotomy can be performed in patients with switch C septum, concern over the adequate size of the right ventricle, straddling AV walls, serious confounding medical conditions such as prematurity, necrotizing enterocolitis, or subarachnoid hemorrhage. Taussig-Bing anomaly without arch obstruction involves an arterial switch with VSD closure, so in which the great arteries are transected and coronary buttons are harvested, and coronary buttons are reimplanted on the neo-aorta with reconstruction of the neo-aorta and the neopulmonary artery, and VSD is closed either transatrially or transventricularly. One thing to note in these cases is usually majority of the cases Lecomte maneuver is not needed in Taussig-Bing malformation. In those with the arch obstruction, we need to do arch augmentation along with an arterial switch operation and the VSD closure. In those with subpulmonary VSD and pulmonary stenosis, we have four options: Rastelli, Reeve procedure, Nikaido operation, and pulmonary root translocation. Rastelli operation includes intraventricular tunneling of left ventricle to the aorta, followed by establishing the right ventricle to the pulmonary artery continuity using a conduit. In Reeve's operation, we enlarge the right ventricular outflow tract, in which we transect both the great arteries. We pass a Hagar through the pulmonary annulus to define the infundibular septum, and infundibular septum is resected to enlarge the left ventricular outflow tract, and intraventricular tunneling is done to divert the left ventricle to the aorta. The cardiac end of the pulmonary artery is overseen. Lecomte maneuver is performed, and the main pulmonary artery is brought anterior to the aorta, and the posterior part of the main pulmonary artery is directly anastomosed to the right ventricular incision, and anteriorly it is augmented with usually a pericardial patch with or without a monocusp wall. Nikaido procedure, also called as aortic translocation, wherein we mobilize the entire aortic root along with the coronaries. Sometimes coronary buttons have to be harvested based on the coronary anatomy. Left ventricular outflow tract is enlarged by incising the VST and resecting the subpulmonary stenosis. Then the LV is, the aorta is translocated posteriorly and anastomosed directly in its posterior aspect. A patch, whether autologous pericardium or a PTFE patch, is used to tunnel the left ventricle to the aorta through the VST, and the pulmonary artery and the left ventricular continuity is established either using an autologous pericardial patch with or without a monocusp wall or a conduit. In patients with a good pulmonary wall, we can use what is called as a pulmonary root translocation, wherein the intracardiac part remains the same, that is left ventricular outflow tract enlargement and tunneling of the left ventricle to the aorta. However, the pulmonary artery is mobilized from its root, then translocated anteriorly and anastomosed directly to the right ventriculotomy incision posteriorly and augmented anteriorly with a pericardial patch. Hugh et al. Developed a technique called as double root translocation for patients with DORV VSDPS, in which aortic and the pulmonary root are mobilized and excised. The ascending aorta is transected and the coronary arteries are detached from the aortic sinus. Majority of the cases require Lecomte maneuver. Left ventricle to aorta and the right ventricle to pulmonary artery continuity is established. A single walled Bowen jugular vein patch was used to repair the right ventricular outflow tract and enlarge the stenotic main pulmonary artery. DOR with remote VST type. The goals of the two ventricular repair with remote VST with or without RVOTO is to construct an optimal intracardiac tunnel between the VST and either one of the arterial walls. The ideal tunnel should be as short as possible to avoid a long non-contractile area on the surface of the interventricular septum. The tunnel should also be non-obstructive and avoid interfering with the tricuspid wall apparatus. True ventricle repair is best performed in early infancy rather than in the neonatal period. Initial palliation with a systemic to pulmonary artery shunt or a PA band therefore may be required. The options we have are intraventricular tunnel repair to the aorta, arterial switch with intraventricular tunnel to the pulmonary artery. Intraventricular tunnel repair to the aorta depends on the presence of an adequate distance between the tricuspid wall and the pulmonary wall, as well as the ability to negotiate around the tricuspid subalveolar apparatus. Tunnel repair to the aorta may require resection of the parietal band, reimplantation of the conal tricuspid papillary muscle on the tunnel patch, VSD enlargement either superiorly or anteriorly, and resection of the subaortic conus. If for anatomical reasons the VSD cannot be tunneled to the aorta, an arterial switch with tunneling of the VSD to the pulmonary artery may be preferable. This approach frequently results in the creation of a shorter tunnel and may result in less interference with the subalveolar apparatus of the tricuspid wall. The Lecomte maneuver is optional depending on the great vessel relationships. This diagram shows the interventricular tunnel repair in a case of DORV remote VSD. As shown, the presence of tensor apparatus of the tricuspid wall makes the construction of a tunnel from the VSD to the aorta impossible. The VSD is enlarged superiorly when it is restrictive. The VSD is tunneled to the pulmonary artery as shown. The intracardiac tunneling of the VSD to the pulmonary artery is followed by an arterial switch operation. The tricuspid wall and the infundibulum septum are spared. As shown in the figure, the left ventricle is tunneled to the pulmonary artery, that is to the neo-aorta, which is depicted after completion of an arterial switch with a Lecomte maneuver. 2 ventricle repair of DORV, remote VSD with RVOTO. RVOTO can be valvular, subvalvular, or it can be in the form of pulmonary atresia. An intraventricular repair or an arterial switch VSD closure, as described previously, may be supplemented with a right ventricular infundibular patch augmentation to successfully repair the defect. When the RVOT obstruction is valvular and the VSD can be tunneled to the aorta, the pulmonary outflow tract is closed and a Rastelli type or preferably Rev operation can be performed. Modification of the Nicardo procedure adapted to address this anatomy by Hu et al. Single ventricle repair of DORV, remote VSD with or without RVOTO should be performed in patients with significant ventricular hypoplasia, severe atrioventricular valve straddling or overriding, switch is VSD, in which case the true ventricular repair is not possible. Significant cyanosis or pulmonary overcirculation is initially palliated with a systemic to pulmonary artery shunt or pulmonary artery band respectively. This is followed by a KO pulmonary connection. If tunnel closure of the VSD produces a critical reduction of the right ventricular volume, a 1.5 ventricle repair can substitute for a Fontan procedure. Late restriction of the VSD can occur after Fontan palliation in patients with DORV and remote VSD, leading to left ventricular exclusion and hypertension. Enlargement of a restrictive or borderline VSD at the time of Fontan palliation has to be done. DORV with AVSD. These patients usually present with RVOTO, TAPVC and frequent intestinal malrotation requiring a LAD procedure. Compared with AVCD associated with tetralogy of Fallot, where Down syndrome is frequently associated, the patients with DORV-VSA generally have a normal genotype. The AVCD anatomy is typically Rastelli type C. Complete repair is performed after 6 months of age. Therefore, in the presence of severe cyanosis, a palliative systemic to pulmonary shunt is performed. Emergent repair of the obstructed TAPVC is undertaken simultaneously with shunt procedure. Post-operative pulmonary valve competency is desirable in these patients, necessitating the placement of a right ventricular to pulmonary artery conduit when the intraventricular tunnel obstructs the RVOT. If the intraventricular tunnel causes a significant reduction in the right ventricular volume, 1.5 ventricle repair is done. Despite the technical complexity of performing a 2 ventricle repair in DORV-AVCD, some groups advocate a 2 ventricular repair based on superb early and intermediate term results, performing a complete repair in the majority of the patients who presents with DORV and AVCD. DORV with straddling valves. Some authors have documented better survival after Fontan palliation in patients with various complex forms of DORV, including patients with straddling atrioventricular valves. Others have successfully performed biventricular repairs in this high-risk group of patients. Shen et al. Found an 18% incidence of late sudden death when they analyzed 89 survivors of DORV. Cox proportional hazards multivariate analysis demonstrated that older age at the time of operation, perioperative or postoperative ventricular tachyarrhythmias, and third degree atrioventricular block were significant risk factors for the sudden death. This high incidence of late sudden death has not been reported in more recent surgical series of DORV. In repeat DORV patients, during follow-up, we should look into the development of subaortic obstruction, subpulmonary obstruction, AV valve regurgitation, conduit failure, either stenosis or regurgitation, neo-aortic regurgitation in patients with arterial switch operation, coarctation or recoarctation of the aorta in patients with hypoplastic arch, small or dysfunctional RV, rhythm problems such as heart block, atrial arrhythmias, ventricular arrhythmias, sudden death, endocarditis and thromboembolic phenomenon.